Kirtan had, and given his status as a resident, limited availability in limited daylight hours, and wanted to present this case, and happy to hear it. And I think Gerardo is going to be one of our discussants, if I'm not mistaken. Fantastic. And we need a second discussant as well, if someone would be excited to discuss a neurology case with Gerardo, Kirtan, and myself. Anyone? Someone is being voluntold, a term I learned recently, to play along.
Hey everyone, I would love to, but I'm actually at work, so I will be listening on next time. I promise. I've been dodging Neuro VMR on purpose. No, I'm just kidding. I'm happy to discuss next time, but I'm kind of in between seeing patients.
No worries. Real patients priority over CP solvers, virtual patients, so to speak. Okay. Great idea, Maria. You're reminding me of my old tricks. Kirtan and Gerardo, do you want to introduce yourselves and inspire someone else to join?
Hi, friends. Uh, Good morning. Thanks for joining on this VMR. Firstly, I wanted to thank Maria and Aaron for adjusting their time so that we can have this VMR on Saturday. I'm super excited for this case, and this is one of the most memorable cases that I have had so far. And it's very special and it's very close to my heart. So I'm excited to be here. So please, guys, volunteer to discuss, and I'm sure you will enjoy it. And it's not very complex, like not too many things. It's relatively straightforward, so it should be all right.
Not very complex for Kirtan means like 12th level calculus instead of quantum physics.
And I think I can introduce myself. Good morning, everyone. And my name is Gerardo Luna. And well, yesterday I found out that I could co-discuss this case, and I'm very happy to be here. And because like I really love neurology, and I'm also very scared because this is a curtain case. But I hope that I will do my best.
Wonderful to have you. Excited to have some new neurophilia in our group after our wonderfully successful neurology match this year with Maria, who found her love for neurology on CP solvers. Great to have you joining our big neuro love family, Gerardo. And you don't have to love neurology to join. You can actually not like neurology at all, and hopefully this will help diminish your neurophobia, because we have the luxury of talking about a patient who's not in front of us being a mystery or getting sick, or otherwise we can do that here in the safe learning space that we have. So would anyone like to join? We could just do myself and Gerardo if nobody is interested.
Hey, hi. Good morning.
Hi.
Hey, hi. I'm Rahul. Good morning, everybody. Yeah, I'm Maths 2025 applicant. I just came to US 2 days ago. I'm in Hartford currently. I'm gonna join observership at Griffin Hospital, Derby from Monday. I'm excited to discuss the case.
Oh, fantastic, Rahul. Welcome. Are you going through the match in neurology or?
Yeah, combined neuro and IM.
Neuro and IM, fantastic. Okay, welcome. Welcome to the US. Welcome to CP Solvers. And welcome to Neuro VMR. Let's do it. Is everyone who wants to be, needs to be a co-host, co-hosted and scribing and everything? Thank you, Maria, keeping us on task here as always. We appreciate it. Okay, Kirtan, do you want to tell us just the chief concern, and we'll get our discussion going?
Sure. So firstly, as we always have to do, right, that the title of the case. So the title of the case is When the Stars Align, and a Soulful Steering Diagnosis. So the chief complaint is a numbness and tingling of the lower extremities with difficulty walking for 3 months.
Okay, lots of richness in the chief concern right away. Gerardo, do you want to tell us what you think? You can, if you'd like, try to interpret Kirtan's poetic title. He has given poetic titles in the past that really only, I think, truly reveal themselves in the end. But or you can go right to the chief concern.
Yes, I would love to. When I think that this case is about when in a patient you find a lot of things that can teach you a lot. So I'm very excited to discuss this. And well, for a patient that presents with numbness and tingling in the lower extremities, the first thing that came to my mind if this could be a length-dependent neuropathy, and because this is the lower extremities where the longest nerves go to, and difficulty walking can be a lot of things, right? It can mean sensory ataxia, it can mean cerebellar ataxia, it can be apraxia, it can be a lot of things, but it can also be due to this possible length-dependent neuropathy, polyneuropathy, right? So since this is in a sort of chronic pattern, because it has been going on for 3 months, I wouldn't consider something like, for example, Guillain-Barré syndrome, because it is an acute syndrome, right? But there is a chronic form of this type of polyneuropathies that include that look like Guillain-Barré but are chronic, right? So I would think about that diagnosis, which is chronic inflammatory demyelinating polyneuropathy, if I'm not mistaken. I don't know if I'm butchering the name. So I would think that those are my first thoughts, and I am happy to know what are the Potabatini thoughts. I hope I am pronouncing your name right.
Yeah, it's correct. It's Rahul, Puttabathini Rahul. Yeah, thank you so much for your efforts. So may I know what's the patient age is? Age of the patient?
Yeah, Rahul. So what we do in these, first we just talk about the chief concern in the abstract here to get a sense of how you would approach it, and then once we've discussed that, we'll get more information about the history to see how that helps us refine our localization and differential diagnosis. I know it's a bit of a false exercise. You would always know the age of the patient first, but this allows us to focus a little more on some of the localization differential diagnosis hypotheses before getting into the HPI. So the age will come soon. If you'd like to comment on just the chief concern, you're welcome to, or else you can discuss the HPI after we hear that. Up to you.
Yeah, got it. So depending upon the severity, it's chronic for 3 months. I would think in terms of CIDP, as Gernand has commented, and maybe because I don't have any age here, I'm not able to comment much more on the pathogenesis and everything. Like maybe if she has exposure to any kind of toxins or any the chronic elements like diabetes can also result in numbness and tingling sensation, and also the vitamin deficiencies, especially with vitamin B12 will end up in the numbness and tingling. Yeah, right. And sometimes MS, multiple sclerosis, can initially present as numbness and tingling sensation. Yeah, right now I have these kind of broad differentials, but because of lack of age, I'm unable to categorize you know, if the path of, yeah, yeah.
Can I make one final small
Yeah.
comment? Just because I remembered something about that one neurologist, one very famous neurologist here in Peru taught me, which is that there are a lot of polyneuropathies, right? But there are 3 main causes, which is alcohol, diabetes, and a vitamin B12 deficiency. So our thinking should be in those 3 main most common causes, right? So that is a really good teaching that I think is useful here.
Fantastic. All great points from Gerardo and Rahul. So yeah, a couple of points here. So numbness and tingling as a concern tells us we're somewhere along the somatosensory pathways, right? So I always like to begin with a review of some of these pathways, not for pure academic purposes, but because they help us understand the potential localizations of these symptoms, because it's easy to hear numbness and tingling and think neuropathy, and probably most of the patients we see who have numbness and tingling in their lower extremities do have neuropathy, but it helps us keep a broad frame before anchoring on a common diagnosis, which may ultimately be correct, but make sure we stay broad early on. So the somatosensory pathways essentially trace the same pathway as the motor pathways, just in reverse. The motor pathways are going from the brain through the brainstem, spinal cord, nerve roots, nerves, neuromuscular junction, and muscle. And the somatosensory pathways are coming back from sensory receptors through peripheral nerves, through dorsal roots into the spinal cord, also through the brainstem up to the brain, right? And so there are two somatosensory pathways for the body: the dorsal column medial lemniscus pathway and the spinothalamic, also called anterolateral pathway. And for reasons I'm not aware of, or I'm not sure if anybody knows the answer to why this happens, different sensory modalities get split up. So vibration and proprioception are carried in large myelinated fibers of peripheral nerves that then go through dorsal roots, through the dorsal columns. Those go up to the lower medulla. We won't go through all the details of the pathway, but that's where the crossing happens. Then they go up to the ventral posterior lateral nucleus of the thalamus and to the hemisphere, such that just like the right brain is controlling the left side of the body, left brain, right side of the body, the right brain ultimately receives somatosensory information from the left side of the body, and the left brain ultimately receives somatosensory information from the right side of the body, and all this information lands in the somatosensory cortex, which is the post-central gyrus, the first gyrus, well, the most anterior gyrus of the parietal lobe. And then the pain and temperature pathways follow a similar trajectory, but have a major difference, and that's that they cross in the spinal cord itself. So rather than traveling in large myelinated fibers, the pain and temperature pathway travels in small unmyelinated fibers. Those arrive through dorsal roots in the spinal cord, and then right away the pathways cross to enter the anterolateral pathways in the anterior and lateral spinal cord. So this pathway has crossed the whole way. So it goes up, it doesn't need to cross in the brainstem like the other long tracks, corticospinal and dorsal column pathway, goes up also to the ventral posterior lateral nucleus of the thalamus and up to the somatosensory cortex. So because of that crossing in the spinal cord, pain and temperature sensation always localizes contralateral when it's unilateral. Okay, so we could have something in the peripheral nerves here. Gerardo made an important point of length dependence. So we have peripheral neuropathies. There's many ways to categorize them. One is by whether they're sensory or motor or sensory motor. Most commonly in practice, they're sensory or sensory predominant. And another is whether they are length dependent or non-length dependent. Length dependent meaning they're affected the longest fibers first. That means you're going to get symptoms beginning in the toes. Those are the longest nerves that have to travel all the way from the lower spine to the tip of the toe. And you won't get any symptoms in the hands really until the progressively shorter nerve fibers are affected. And that means until the numbness and tingling has moved up to about the mid-shin level, there shouldn't be any symptoms in the fingers if that's a length-dependent neuropathy. And when the neuropathy is length-dependent, Gerardo, do you know what that signifies for the pathophysiology?
Yes, so it differentiates between axonal and demyelinating, because demyelinating is length dependent and axonal it's not.
Perfect until the last bit. Yeah, axonal is length dependent and demyelinating is non-length dependent. Yeah.
Okay, I mistaken.
Yeah, no problem. Yeah, that's right. That's what they differentiate, these pathophysiologies. And that is important because axonal neuropathies have a different etiologic differential diagnosis than demyelinating neuropathies. The axonal, you can understand if there's a problem with axonal physiology and things have trouble making their way down the axon, then the longest fibers are going to have the most trouble. So if you have a traffic jam on a major highway, your commute is going to be very long. If you're a short nerve just going from the neck to the deltoid, and you only have, or the neck to the trapezius or something like this, then you only have this little bit. If you just had a traffic jam on one block on your way to work, then it's not going to cause you too much trouble, right? So the axonal neuropathies cause the longest fibers to be affected first, and then progressively shorter fibers. The demyelinating processes, well, if all the nerves get demyelinated at once, both short nerves and long nerves will be affected at the same time. And so you'll have both proximal and distal effects early on. Now, the longest nerves still have the most myelin, so you're more likely to get more demyelination or more effective demyelination in the longest nerves. So demyelinating neuropathies are often still distal predominant, even though they're not length dependent. What do I mean by that? Often the hands and feet are affected early in a demyelinating neuropathy, but the hands are affected at the beginning, whereas they would not be in an axonal neuropathy. So if you think about it, the longest nerves, if you start picking off myelin in these nerves, it's going to be the hardest for the longest nerve to do its job, to have the myelin speed the conduction, as opposed to the effects on shortest nerves. So if you see a patient who has numbness and tingling in the hands and feet, and they say, well, it was in the feet really for years before it started affecting my hands, that's a length-dependent axonal process. And if the patient says, no, it was my hands first or my hands and feet at the same time, that suggests non-length dependent. That's the less typical pattern, makes you think of demyelinating. And axonal processes are toxic metabolic etiology usually. So as Gerardo said, alcohol, B12, diabetes, and demyelinating are often immune mediated, things like Guillain-Barré or CIDP. Numbness and tingling in the bilateral lower extremities, though, isn't necessarily a neuropathy, although that would be a common cause. This could still be in the spinal cord or in the cauda equina, if it were in the thoracic cord or below. So when I hear bilateral legs, whether weak, whether numb, I just think I'm below T2. The end of the innervation of the hands is sort of upper extremity, sort of T1, T2. And that could be thoracic cord, that could be lumbar cord, that could be roots of the cauda equina, or that could be nerves. We know because there's sensory loss here that it can't be neuromuscular junction or muscle. So peripheral neuropathy certainly jumps to mind, but we can't exclude at this point a spinal cord process causing numbness and tingling in the lower extremities. We won't do our usual deep dive on walking. Well, I'll do a 1 minute. I'll do a shallow dive. Gerardo mentioned some causes of difficulty walking. The way I like to think about this is you have certain elemental functions you need for walking, and then you need to coordinate those elemental functions. So to walk, you need to have strength, you need to have sensation, and you need to have coordination. So those three pathways need to be intact. You need also to have vision and vestibular function intact as well. And then you also need to have the overarching control of gait, which happens in the hemispheres, in the basal ganglia and the frontal lobes. So if the patient is weak, if the patient is numb, if the patient has ataxia, it might be one of the elemental functions affecting gait. If those are all intact on your exam, well, we check the gait last, although actually we see it first when the patient walks into the room. Then we're thinking it's some higher order problem, something like Parkinsonism, normal pressure hydrocephalus, gait apraxia, something that's there's some problem synthesizing those elemental functions of motor, sensory, and coordination. So here we hear numbness and tingling, difficulty walking, suggests, as Gerardo said, some type of sensory ataxia. So we're going to hear the history. You're going to get the age, Rahul, as you were hoping for. And what are some other things, if we're thinking the localization could be in the nerves or in the spinal cord, what are some important questions to ask to distinguish those localizations, either Rahul or Gerardo, distinguishing spinal cord from peripheral nerve?
Yeah, I can go first.
Sure.
Yeah, maybe any spasm in the legs. Maybe if
Okay.
it is affecting the motor pathway with associated tingling sensation,
Okay.
and any involvement of bladder and bowel.
Yeah. So bowel bladder is a big one, right? You don't get bowel bladder involvement in neuropathy.
Peripheral.
And
Right.
autonomic neuropathy, you could get some potentially, but usually it's more orthostasis in those settings. But yeah, if you have the spinal cord or the cauda equina, bowel and bladder involvement is not omnipresent, but it is often present. But with neuropathy, you don't get that. So that's a key distinguisher. Is there any back pain? Sometimes you have with spine, sometimes you don't. And then 3 months, both of you use the word chronic for that. I would probably call 3 months subacute.
Right.
It's probably no firm boundaries around these, but 3 months is moving along relatively quickly. This patient isn't coming with a problem for years or a year. So I think this is moving along relatively quickly. And that helps us frame some of our differential diagnosis as well. As Gerardo said, if we heard numbness and tingling evolving over days, we might worry about an acute inflammatory process like Guillain-Barré syndrome in the peripheral nervous system, transverse myelitis in the central nervous system. And both inflammatory processes, or an infectious process, a viral myelitis, an epidural abscess for the spine, something like that. But 3 months sort of puts us a little bit in a different category. In the peripheral nervous system, Gerardo, you mentioned CIDP, chronic immune demyelinating polyradiculoneuropathy, an immune-mediated, I call it sort of a cousin of Guillain-Barré syndrome, a sort of a subacute sensory motor neuropathy. This PACE would be decent for that. Usually those patients will have some weakness, but we'll find out. Rahul mentioned vitamin B12 deficiency, very common condition. And this would be a very reasonable presentation for that. These patients get dysfunction in the peripheral nerves. It's an axonal length-dependent neuropathy, and or the dorsal column and corticospinal tracts, that's subacute combined degeneration. So if this patient had any risk factors for B12 deficiency, that might be something to ask on the history as well. What risk factors for B12 deficiency, what might we ask about, Gerardo or Rahul?
Maybe alcohol consumption, for example, or maybe a person that is following a strict vegan diet.
Yeah,
without any supplementation.
That's right. Yeah. So alcohol I usually think of with thiamine deficiency, but yes, if someone is taking so much alcohol that their nutrition is diminished, and then they could be B12 deficient as well. Thiamine deficiency, by the way, can also cause a neuropathy in dry berry.
And any gastric bypass surgeries?
Gastric bypass surgery, strict vegan diet. As a follower of a strict vegan diet, I can tell you, I've done my research. It is very hard to get enough B12 from a strict vegan diet. I need to take a supplement. I checked my levels, never fully deficient, but coasting down. So you do need to supplement a vegan diet. And then, correct me if I'm wrong, internists, but metformin, I believe, also inhibits B12.
Yes, and
right.
PPIs also.
Yeah, it's also.
Yes.
Excellent. Okay, well, we've spent a lot of time on the chief concern, as I like to do, but hopefully this has sort of set a landscape for us of possibilities, peripheral nervous system versus cord, a subacute process that, as we hear the history now, are going to allow us to narrow our focus to a particular localization and differential diagnosis. So Kirtan, what did you find on the history? And I defer to you whether you want to fill in the past medical as well at this stage, up to you.
Right. So, Aaron, I was wondering if you are fine. I can give the HPI, past medical history, and even examination so as to make sure that we move the case along. What do you think?
Many aliquots here. Let's hear everything up to the examination. But I'll make sure we'll move it along.
That's fine. Sure, no worries. Okay. So we have a 23-year-old gentleman who endorses progressively worsening tingling in all the toes for last 3 months. Onset of symptoms was insidious and he doesn't recall any antecedent flu-like symptoms, diarrhea, nausea, vomiting, or trauma. Tingling was accompanied by numbness extending to the level of thighs. He also has unsteady gait, recurrent falls, and difficulty in standing when eyes are closed. Now, since last 1 month, he also has paresthesias in fingers. And regarding the review of system, he denies any weakness, burning pain, diplopia, hearing changes, vertigo, headaches, fevers, chills, shortness of breath, bowel or bladder disturbances, or photophobia. Regarding the past medical history, medications, and social history, so he has no relevant past medical history. He is actually coming to the hospital for the first time. He is not on any medications. Regarding social history, he denies any illicit drug use, including alcohol, opioids, cocaine, marijuana, or any over-the-counter supplements. And that's the end of 2 aliquots. And since it's a lot of information, I will put everything in the chat so as to make sure that none of the symptoms are missed.
Yeah, I think the only thing I think that you said that was important that might not have made it onto the board here was you mentioned the hands are starting to become involved. Is that right?
That's correct. Since last 1 month, now the paresthesias are in the fingers as well.
Okay. I know Kirtan wants to move the case along, so maybe we'll just have one of you briefly discuss, and I will try to keep my response brief as well. Either Rahul or Gerardo, given all the many things we've discussed, you've heard the history now, what is sort of moving higher in your differential diagnosis? What is moving lower, or are we still in the same place?
Okay, can I go first?
Please.
Yeah, so based upon the history and along with rhomboxane positive, like this recurrent falls with eyes closed, so I could think of any possibility of any localization of cord involvement. That could be made one of the differential. And also it is involving the hands. I think it is progressive towards the, I think maybe it's progressive towards the cord. Yeah, I'm just thinking it not in the terms of peripheral neuropathy. Maybe there is any involvement in the spinal cord. That is my thoughts.
Yeah.
Because
great.
it's also, yeah.
Okay, great thoughts. And then just since Kirtan, by saying we need to move the case along, I suspect has some twists and turns ahead. Gerardo, I'll have you interpret the exam after we hear that, just so we keep both of you involved, but not belabor early portions of the case Kirtan is telegraphing to us. So yeah, I think for the localization, we're hearing the tingling in the toes, and that's sort of kind of insidious and moving along. I'm probably still with everyone's initial impression of peripheral neuropathy, and that it's sort of starting to arrive at the fingertips. You could also imagine a cord process that's sort of starting in one part of the cord and kind of as it evolves, going from leg fibers to hand fibers. These are all laminated in unique ways with the legs medial and the upper extremities lateral for the dorsal columns, and the hands medial and the lower extremities lateral for the other tracks. You can imagine some process kind of moving, but for yeah, maybe. So maybe an expanding cord lesion. We're not hearing about bowel bladder, something else that's sort of putting us in nerve. And then that we started in the feet and really stayed in the feet for some time and only then moved to the hands does make us think of a more length-dependent process, so an axonal process, and this is sort of subacute. So CIDP is a demyelinating condition, so we would expect a non-length-dependent presentation in that case. So it wouldn't quite fit with that. Do either of you know if we are in the neuropathy category? And our exam is going to help us figure that out. Just a short answer type question. Other differential diagnoses for subacute neuropathies? It's a kind of unique category. Many of us have seen, or if not, will see, countless chronic length-dependent neuropathies in clinic because diabetes is so common, because alcohol use is so common, and this sort of not this length-dependent sensory problems in the feet, absent ankle reflexes, maybe some gait unsteadiness, very, very common and chronic, right? So you'll see many of those. And as I've been teaching more recently, sort of formulating it this way, you'll see, as I said, countless patients in clinic whose neuropathies follow this pattern. They are sensory, they are length-dependent, they are chronic, and they are symmetric. If your patient's neuropathy violates any of those four, that is a red flag, and it needs a further workup. As Gerardo said, if it fits all of these four, sensory, length-dependent, chronic, and symmetric, you send vitamin B12, you test for diabetes, and you send an SPEP, which is really a rule out because it's very rarely going to be significant or abnormal. But if it violates any of those, meaning there's a significant motor component, meaning it is subacute, meaning it is asymmetric, or meaning that it is non-length dependent. Sorry, I said them outside my usual order. So if you are non-length dependent, you're worried about demyelinating. That's a whole different category. If it's subacute, you're in a very different category. If it's asymmetric, people start wondering mononeuropathy, multiplex vasculitis, et cetera. And if there's a significant motor component, again, you can see that with diabetes. It's just not common. Does anyone else know what's in this subacute category? Yeah. So paraprotein associated neuropathies is a very, I find, complicated area of neurology. So paraproteins can be seen in myeloma, but in a number of other diseases, POEM syndrome, polyneuropathy, organomegaly, endocrinopathy, M-spike, and skin findings. And these can cause a subacute neuropathy. And hopefully you can find the answer on the SPEP and with light chains, et cetera. So those are worth considering in this category as well. Now, I have seen cases that really sound length dependent. And as I mentioned before, I've started revising saying, length dependent means distal and non-length dependent means proximal and distal, but reminding people that demyelinating can still be distal predominant because the longest fibers have the most myelin and so can be the most affected. So I've seen some cases where I say this really sounds axonal. It was feet, and then hands. But if the presentation is very distal and you still find areflexia everywhere on exam, it tells you, no, both short and long fibers are being affected here. So that can be a clue when the patient isn't sure if it was the hands or the feet first, or maybe the hands, we just notice more when they're numb compared to the feet. If there's areflexia everywhere as opposed to just the ankles, areflexia everywhere would say, no, this is actually non-length dependent. Okay, so let's hear the exam. So what am I curious about in the exam here? Well, is this really a pure sensory problem? Sounds like it. So vibration, proprioception, Romberg, all sensory. We haven't heard about any weakness. And if it is pure sensory, what's the pattern of sensory loss, length dependent, non-length dependent, and what's the pattern of reflex involvement? We may get surprised here. Maybe this is a myelopathy behaving funny, and then after 3 months, we should see upper motor neuron signs if that's the case. You may say, but there's no weakness. Sensory, we would get upper motor neuron signs. No, but if it's in the cord and affecting the corticospinal tracts, even without weakness, we may see some upper motor neuron signs. If those are absent, then we are squarely in the periphery, as was folks' initial impression. Okay, Kirtan, with your tuning fork, your reflex hammer, tell us what you found here.
Sure. So examination is really crucial in this case. Vitals, unremarkable. General examination, you see the patient is in wheelchair. Regarding other systems, everything is fine. Respiratory system, cardiovascular system, GI system, skin. There are no contractures, no ulcers anywhere on the skin. Now coming to the neurological examination, starting with cranial nerves. All the cranial nerves are intact. Mental status, alert and oriented ×3. Sensory examination, patient has decreased light touch, pinprick, and temperature sensation till the level of knees in lower extremities and elbows in upper extremities. There is severely reduced vibration and proprioception only in the lower extremities up to the level of ankles. Motor examination, the strength is 5 out of 5 throughout in upper as well as lower extremities. Reflexes, in upper extremities, they are 1+ and they are absent in lower extremities. Plantars are downgoing bilaterally. Cerebellar examination showed profound dysmetria on finger to nose test. There was dysmetria evident even on heel to shin test. Regarding the gait examination, the Romberg sign was positive. So patient was unsteady with the eyes closed, but with the eyes open, patient was not swaying either in either of the directions. But patient had wide-based gait in all the positions, whether eyes are closed or open, patient had wide-based gait, and patient was not able to do the tandem gait. And that's the end of examination.
Okay, fantastic. Lots of rich information here. Gerardo, what do you make of all this, particularly with respect to the localization?
Yeah, so I think that the most reliable, I would think that the most reliable clinical sign that would indicate that there is no spinal cord damage is the Babinski, negative Babinski, but that is what point me to the periphery. And in this case that we were asking is if this patient had a motor weakness. At first I thought if he's in a wheelchair, he might be weak, but I think that this him being in a wheelchair can be due to a sensory polyneuropathy, right? Because motor strength is preserved. So I think that we are facing a subacute polyneuropathy that behaves in an axonal pattern, right? Because it is length dependent and it is in an stocking and glove pattern. So I would think of an axonal axonal demyelinating polyneuropathy. Pardon, an axonal polyneuropathy. I'm sorry. And well, and also for the cerebellar signs, we know that if we have a compromise of anything that comes from the dorsal root ganglia, we can have cerebellar signs, right? And that is what makes the dysmetria in this patient. And also, well, the Romberg test confirms our suspicion. But I am curious to know more about this patient because he's a male and he's 23 years old. And I was thinking about a patient that has no past medical history and presents like this. This is very, I would think, unusual. So what I started thinking was in our immune causes, right? It could be, for example, or genetic causes like Charcot-Marie tooth could present. I don't know if in this severity, but I would consider that. And I was also considering NMOSD, MOGAT, NMOSD and MOGAT, but presenting in a very atypical way. But this, I don't think that is the case, because obviously there is no signs of myelopathy, right? I mean, there is no signs of transverse myelitis. So those are my thoughts. Yeah.
Brilliant thoughts. Brilliant thoughts. Okay, lots to highlight there in your excellent discussion. So first of all, this is in the periphery, right? Is there any way this could still be myelopathy at 3 months? Probably not. Understand that in acute myelopathies, transverse myelitis, so people are moving away from that term. So let's say a viral myelitis or an inflammatory myelitis over days, well, the upper motor neuron signs take time to come out, so you could get fooled. A fully, quote, transverse myelitis that's affecting the anterior horns, right? Those are the lower motor neurons, even though they're in the spinal cord, so you could get lower motor neuron findings. All that said, I agree with you. This patient has pure sensory loss, no motor, has absent reflexes in the lower extremities, diminished in the upper extremities, no Babinski sign. We are in the periphery. Another point just to highlight is that Kirtan showed us that pinprick, temperature, vibration, proprioception are all out. So if we're in the periphery, we're affecting both large and small fibers. This is another clue that we're not in the spinal cord, because the dorsal columns are dorsal and the spinothalamic tracts are anterior. Do we have some type of X-shaped lesion that left out the lateral corticospinal tracts? That is stretching the imagination a bit, isn't it? And no bowel and bladder. Okay, so we're in the periphery. Are we in the peripheral nerves? So that would certainly be the most common localization, but two other peripheral localizations to bring to mind. One is a polyradiculopathy. When you think radiculopathy, usually you think someone has shooting pain down their arm or down their leg, and from a compressive etiology, foraminal stenosis due to osteoarthritis, something like that. But you can get conditions that selectively affect the nerve roots that could look like this, a diffuse polyradiculopathy. And in fact, the P in AIDP for Guillain-Barré syndrome and CIDP is polyradiculoneuropathy. The roots are involved. And the other localization that probably only familiar to neurologists, because this is pretty uncommon even for us to see, is a ganglionopathy, a pathology specifically affecting the dorsal root ganglia, which can look like this as well. Because if it's a neuropathy, it's affecting both large and small fibers, that's okay. Or could it be affecting the ganglia, where all of these large and small fibers are ultimately going? What's probably most striking here, as Gerardo mentioned, is this patient is in a wheelchair even though they're not weak. It means their sensory loss is so profound that they can't walk. Can you see that in a really severe sensory neuropathy? You can. You can also see that in a sensory ganglionopathy. I've only seen maybe 1 or 2 of these in a decade plus. They're pretty uncommon, but they have a unique differential diagnosis. Is this a length-dependent neuropathy? I want to agree with you, Gerardo, but this would be the kind of case where I'm not sure. It's so confluent. It's the arms and legs. Probably if it was non-length dependent, we'd have no reflexes in the upper extremities. If the patient is this impaired sensorially rather than 1+. But this might be the kind of case where you get an EMG nerve conduction study with the focus here on the nerve conduction study to say, just want to see, because that can tell you, is this axonal or demyelinating based on the parameters? Because clinically it's so advanced, confluent, it's moving so quickly. It's not like the patient said, for years I've had the toes and then the hands. Then you can be pretty sure. This has all happened in a few months. More myelin in those long fibers to the legs than in the arms. I'm actually not sure if we are length dependent or non-length dependent. And then brilliant point, Gerardo, about dysmetria. Everyone says cerebellum. But remember how the cerebellum works. It receives sensory information to know where the body is. It receives the plan from the brain, and then it calculates the difference to try to get from where we are to where we want to be. So if you have very impaired proprioception, the cerebellum is missing its key input. Your iPhone, you left your charger at home and it's out of batteries. It's a very nice iPhone, but it's not going to work with no power. And not perfect metaphor, but the cerebellum won't work very well if it doesn't have its main source of input of sensory dysfunction. So it doesn't look like cerebellar ataxia on exam. Maybe Kirtan can tell us with this oscillation perpendicular to the plane of movement. And sensory ataxia, it looks sort of like this meandering, kind of the patient is trying to get to your finger, but the feedback, sensory feedback they're not getting, and it kind of looks like it's sort of circling and looping around rather than this very coarse ataxic tremor. So I agree. I think we can put this all in the sensory system unless this is a cerebellar and sensory neuropathy. Not too many things do that. Friedreich's ataxia, this is too fast for that. And I agree, Gerardo, with your instinct. We are in the subacute category, which really makes us think of something immune-mediated and in the periphery. So CIDP still on the table. Paraproteins, this patient would be pretty young for that. Rheumatologic diseases can all cause neuropathy, which can rarely be a presenting feature. And then for this ganglionopathy, has a unique differential diagnosis. Let me ask, sorry, Gerardo, you want to say something? Go ahead.
Yeah, I didn't want to interrupt, but I wanted to make a comment about the ganglionopathy because I remember that I was reading this book, which is called How to Think Like a Neurologist, and I remember a case where there was a ganglionopathy, a paraneoplastic ganglionopathy, because the doctor that was asking the questions was thinking why there is such a sensory component with no motor component, right? And this could be due to a ganglionopathy because the dorsal root ganglia are in charge of the sensory, of all the sensory nerves, right? So if I'm thinking paraneoplastic ganglionopathy, I would take into consideration, for example, an occult malignancy in this age range. For example, a very small tumor in the testicles could be something that we can search in this patient. If we do not, if we exclude other causes, that would be very rare. But I wanted to make a comment about that case.
Good for you for knowing about ganglionopathy. That's something I learned about as a resident. Do you remember from reading my colleague Ethan Meltzer's book, The Other Differential Diagnoses for Ganglionopathy? It's a unique kind of set of
Sjogren's syndrome. Sjogren's
syndrome. Yep. Paraneoplastic. Yep. And
I don't remember the last one.
okay.
Yep.
It's an interesting list of things. Yeah. Sjogren's syndrome, paraneoplastic, I think anti-Hu, which is one of the antibodies that can sort of cause many different syndromes. Vitamin B6 toxicity, a rare instance in which high B6, high B vitamin causes problems. And then it's reported with HIV. I've never seen that. And then it can be idiopathic. And it can be the presentation of Sjogren's syndrome. The patient may have no dry eyes, dry mouth. So I think that's on the differential here. I agree there is profound sensory ataxia kind of here. You can see that with neuropathy, and you can get a pure sensory neuropathy and the motor fibers being spared. But I would sort of be between those localizations of ganglionopathy and sensory neuropathy. Okay, Rahul, we think we're in the periphery here. We've built a differential diagnosis. We're still not totally sure of the localization. What tests would you order to try to sort this out at this stage?
So I would order nerve conduction study first, and the other routine tests like vitamin B12. And being considering is engage and considering autoimmune etiology, maybe you can order ANA profile and ESR and CRP. And coming to the imaging, we can order a whole spine MRI.
Okay.
Whole spine MRI brain and spinal cord to look for any demyelinating lesions in the cord.
Excellent. So yeah, great point. This could still be vitamin B12 deficiency, actually. This is totally fair game for that diagnosis. We got down the path of some obscure things, but this could be the exact presentation of B12 deficiency, a very profound sensory ataxia with preserved motor. And you don't need to see the upper motor neuron signs that you can sometimes see with subacute combined degeneration. You can see upper or lower motor neuron signs or both, because it can cause neuropathy or dorsal column dysfunction. So B12 is definitely still high on the differential diagnosis. Yeah, because ganglionopathy was invoked, we might check a B6. But I agree with you. This is a great case for a nerve conduction study. These, in my experience, are, all due respect to neuromuscular colleagues of mine, ordered with they're probably over-ordered. If you think the patient has carpal tunnel syndrome on the physical exam and it's not severe enough to recommend them for surgery, you don't need to prove it. If you think the patient has a length-dependent neuropathy and you're sending B12, diabetes testing and an SPEP. You don't need to prove it. But this is the kind of case where you say, and by the way, it's a very uncomfortable test. Those of you who are neurology residents or soon to be, you'll try it on each other. You're giving someone electric shocks. It's I've had it done to me, and it's not that comfortable of a test. There's no effect afterwards, but during the test, it's not comfortable. Needles going to the muscle and whatnot. But this is a good example. So when you're not sure if it's axonal or demyelinating, it's very helpful. If it's a one limb presentation and you're saying, is this multiple nerves or plexus or multiple roots or some combination, then it's very helpful. And then, sure, if you're saying this is carpal tunnel syndrome, the patient has so many symptoms, but I'm not seeing many signs, but they're very disabled. Maybe it's more severe than I can pick up on my exam. And if I'm going to recommend surgery, the surgeons are going to ask how severe it is. So for axonal versus demyelinating, it's great. For precise peripheral localization, is this C6 or is this radial or is this both or is this plexus? It's great. For neuromuscular junction disorders, obviously not at play here, myasthenia, Lambert-Eaton, it's great as well. And then sort of for grading severity of a potentially intervenable compression neuropathy. So I agree, that will be helpful information. That will probably take some time to get. So getting B vitamins cooking, autoimmune labs, totally reasonable here as well, as you mentioned. And then this patient would be young for anything related to what we would find on the SPEP, but that would be part of the workup of a subacute neuropathy. You brought up imaging of the cord. I think we've moved away from the cord, but the ganglionopathies, the ganglia are not easily visible, but do you remember, Gerardo, from this case you read in Ethan's book, what you can see on spine imaging and in ganglionopathy? No worries if not. Again, that's a very rarefied.
So, do you mean like enhancing of the dorsal root ganglia?
Yeah,
Do you
really,
mean that?
yes. You can see enlargement and enhancement of the dorsal roots. Yeah, in these cases. And if I'm not mistaken, someone should double check me. I think our case had this, that you can actually see hyperintensity, not enhancement, but hyperintensity in the dorsal columns, which is sort of hand wave, kind of a dying back, so to speak, of the sensory fibers, which could look like B12 deficiency, but you shouldn't see root enhancement with that. So I agree. If we were going to be stepwise, probably we get the EMG nerve conduction state. Hey, are we in the axonal family or the demyelinating family? We're still not even sure. Let's look there and then decide what labs to send. But probably we, in parallel, send some labs and then see what all we have, and then think about whether we need to take pictures of the spine. Okay, Kirtan. So what did you and your colleagues do here? I'm still not understanding your metaphors with stars and the soul and where to localize the soul. I think Descartes said it was in the pineal gland, and we're far from the pineal gland here. So tell me what you and your did.
Yes. So first, to answer the questions which you had, that regarding this ataxia, the examination, to be honest, we were not sure, but it was documented on multiple occasions throughout the course of hospitalization that he did have this ataxia, and it kind of looked like cerebellar ataxia, to be honest, rather than the sensory ataxia, but we cannot be sure. Regarding the base, yeah.
Oh, sorry. Did you have more to say about that? Because then you've invoked another thing for me.
So like there was no nystagmus for sure, but regarding the ataxia part, like we didn't think that it was the ataxia which you were describing, Aaron, like kind of like this. It was not like that. It was more of the terminal. Yeah. And patient also had like terminal tremor. So we were thinking more of the cerebellar involvement rather than the classic sensory ataxia presenting as cerebellar findings. So just want to clarify that.
I appreciate that. While you're saying that, so it was sort of tremulous at the end. That can be sort of hard to say if it's looks cerebellar pattern or not. Rahul or Eduardo, what if this tremor looked more cerebellar or more like a tremor than a sensory ataxia? What what do we do with that?
If the tremor looks more like cerebellar,
I'm saying
do
it
you
looks
mean?
like more like cerebellar or like a tremor rather than a sensory ataxia. What do we do now?
I am really having trouble thinking about that.
You are correct to have trouble. And I want to just highlight Kirtan saying we looked at this many times and we actually weren't sure. That is neurology. I always tell my residents, embrace the ambiguity. I'm not sure actually on that one.
All right.
Do you have a thought here?
I don't know.
Yeah,
I'm not
I
sure.
love the chorus of I don't knows here. That's right. This is neurology. We never You're all saying that exact answers. I don't know. I will say CIDP, there can be tremor, and it can be kind of a coarse, almost ataxic looking tremor, and I'm not sure we understand why that is. If this looks more cerebellar, there's a set of diagnoses I recently learned about, and we were able to make this diagnosis in a patient recently and get him from bedbound back to walking with a walker, which is an amazing recovery. And that is CIDP is an interesting diagnosis because it doesn't really have a biomarker. It's a subacute demyelinating neuropathy. However, recently there have been described syndromes caused by paranodal and nodal antibodies to the node of Ranvier, that have become sort of a carve out of CIDP. And the new CIDP criteria sort of say, CIDP, they emphasize that this is a pattern of findings that gets this name, but there's no precise biomarker. And there's things that have gotten carved away from it. There are paraprotein-related syndromes that are demyelinating and are subacute and are polyradicular neuropathies, but they have a paraprotein, so they are associated with that paraprotein. They're not CIDP. These paranodal antibodies include antibodies against contactin-1, against neurofascin 155. I believe there are others. And these look like a subacute, they're demyelinating polyradicular neuropathy, but they are not CIDP. They don't respond to IVIG, which CIDP almost always does. And they have a biomarker. They respond more to rituximab. We had a very interesting case that was thought to be CIDP, subacute, non-lent dependent, a lot more motor than this, had a lot of facial weakness, had a very profound, what looked to me, cerebellar tremor. And a lot of people had seen this patient and said, this is CIDP. And, people asked, but there's a lot of facial weakness. And they said, if you see enough CIDP, the seventh nerves or peripheral nerves, you can see, wow, this patient has a lot of tremor. Yeah, if you see a lot of CIDP, they can have a tremor. This was a situation of it was a red flag within a red flag. It's already behaving, so it's demyelinating. It's not your classic lent dependent, and it's behaving oddly for CIDP. And we sent these antibodies, and the patient actually did have anti-neurofascin 155, and you can only get that by sending the CSF to the Mayo Clinic. But worth knowing that when you send CSF to the Mayo Clinic, it's an expensive test. Your hospital might say, are you sure you really need this? And it's expensive. But part of what you're paying for is a consult from the Mayo Clinic. And we called, and the people who you get to speak to are some of the world experts in autoimmune neurology. And we spoke to the person who's published the largest series of cases, who told us this is classic Neuro 155. It's very distal. It's very motor. There's not much sensory. There's a profound facial weakness, profound cerebellar ataxia. This patient's CSF protein was 600. Again, CIDP, you do have an elevated protein, but 600 is really high. So just two things about that. CIDP can have a tremor. So we're not out of the woods for a CIDP diagnosis here. We're not necessarily needing to move away from that. And could this be one of these paranodal antibodies? That was an instance for me where I had read about these. I hadn't seen them, but I just thought, I haven't seen a lot of CIDP, but just everything seems like it's pushing the boundaries for what I've learned CIDP should look like. So something else to throw in that was sort of previously just called CIDP until people discovered these antibodies, and now it's been carved away. And I started thinking about CIDP after this case, reading a lot about it, as sort of a parallel to multiple sclerosis, neuromyelitis optica, MOG, these antibodies that Gerardo mentioned. MS used to be sort of under the umbrella of MS until people discovered these antibodies. When I was a medical student, not that long ago, though, getting longer ago, people would say this is opticospinal variant MS called Devick's disease. Now that is NMO, that is not MS. Different treatment, different disease. And poor MS doesn't have its biomarker that it keeps getting chipped away at. And CIDP, same thing. It's this cousin in the peripheral nervous system. It's demyelinating. It's autoimmune, or it's immune mediated. And then the paranodal antibodies are getting carved away. So what is CIDP? What is MS? Maybe they're all going to get chipped away at as we expand our understanding of these antibodies. Okay, Kirtan, you keep telling me to move it along, or hoping I'll move it along probably, because you have probably 12 more aliquots for us, but there's just so much rich neurology here, and it's a Saturday. What more fun could we have than discussing this case? So what did you get next?
Perfect. So like all the basic labs, CBC with differential, BMP, liver function test, vitamin B12 level, methylmalonic acid level, copper, TSH was fine. HIV, syphilis, hepatitis serologies, Lyme serologies were normal. For the autoimmune workup, ANA, ANCA, cryoglobulinins, C3, C4, rheumatoid factor, ESR, CRP were within the normal range. The heavy metal screen was obtained, so the lead, mercury, arsenic, cadmium was fine. And we did have concern that could this be one of those genetic syndromes which affect the cerebellum and peripheral nervous system. So we know things like Fabry's disease, Friedreich's ataxia, Refsum disease, all those, even spinocerebellar ataxia. But all those disorders have some signature when you are young, and they have other system involvement like retina, which we don't have. Their lipids were fine, their metabolics were looking fine. So we were moving away from the genetics part. And ultimately, patient did get the imaging because of the broad differential. So MRI of the brain with and without contrast was fine. MRI of spine was never obtained because we didn't think that the problem is in spinal cord. Other involvement like CT abdomen pelvis, CT chest was fine. There was no evidence of occult malignancy, organomegaly. They were thinking of organomegaly because we know some disorders which are like lysosomal storage diseases can affect the liver and spleen as well. So that was also fine. Eventually, EMG and CES was obtained, which showed the patient had symmetric demyelinating sensory motor neuropathy in upper and lower extremities. And CSF was also eventually obtained. And CSF showed that opening pressure was fine. The WBC count was 1 in the CSF, which is normal. Glucose was also normal, and proteins were significantly elevated at 400. And this finding was demonstrated again and again on multiple studies as well.
Okay, excellent. Yeah, thanks for mentioning heavy metals. That had crossed my mind a few times, but did not mention. I'm glad you mentioned that's another in this sort of, if you have red flags for neuropathy, again, if it's not chronic, if it's not length dependent, if it's not pure sensory, if it's not symmetric, and you're in this kind of red flags, rare neuropathies, autoimmune, immune mediated, CIDP, paraprotein. Yeah, heavy metals are there as well. Be careful with heavy metals screening. You can get a lot of spurious high values here. Saw a patient recently with a super high arsenic who had no syndrome related to the arsenic, but had been sent as part of a broad workup. We read that, have the patient stop eating fish for a few weeks and recheck. And we did that, and the arsenic went back to normal. So there is some arsenic and mercury in fish. And be careful with these labs when you send them, because the patient has no exposure and you find it, people are going to start to wonder if the patient has been poisoned. And these toxidromes have some characteristic features. But yeah, in this case, unknown diagnosis for neuropathy, first pass, workup negative. It's part of the second pass. Just when you get the values, go read about all the different ways they can be spuriously high, and the patient is probably not being poisoned, hopefully. Okay, Rahul, we have an extensive laboratory, neuroimaging, electrophysiologic, and CSF data here. What are you thinking now for the final diagnosis, or most likely diagnoses, and any other tests you might want to order?
Maybe the antibodies, so you said for 5. Yeah, I'm thinking of that lines. But other than that, right now I don't have any thoughts in my mind.
Great. Yeah. Excellent. Gerardo?
Yes, so I was reading this, what is in the board, and I was wondering first about the myelinating part, because as you said, you were not sure if this was an axonal process, and you were right. But also, here it says that there is symmetric demyelinating sensory and motor in extremities, but we in the past in the exam we found that he had preserved motor strength. So that is something that I am wondering why. But also, as someone mentioned in the chat, we have increased protein and we have decreased a normal level of white blood cells, which is albuminocytologic dissociation, right? So that is a feature that you can find in Guillain-Barré, but also in CIDP, I think, if I'm not mistaken. So that is a possibility, right? But there is also another possibility, I think, because I am, correct me if I'm wrong, please. because you can also have increased protein in other immune mediated diseases, right? Like for instance, multiple sclerosis. Not that this is the case, right? But you can have also in paraneoplastic, I think, or other entities. So I would be cautious in interpreting the albuminocytologic dissociation. And yeah, those are my thoughts.
Yeah, brilliant, brilliant thoughts, both of you. Yeah, so let's address those points. First, excellent. Yeah, we all learn in medical school albuminocytologic dissociation. When you see that on your step exam, it's Guillain-Barré. This is a very non-specific pattern, as you said. High protein, few or not normal cell count or very few cells, non-specific pattern of I'm hesitating because one would say non-specific pattern of inflammation in the CSF, but you can have a high CSF protein just from what's called spinal block, very severe spinal stenosis in older individuals, just from the flow of CSF is such that the protein sort of, I don't know, pools or something. I don't know the exact physiology, but people say you can have a higher protein in diabetes, although I've seen some papers that say that's not really true. And that's when you get a protein of maybe 70, 80, something like that, as opposed to the upper limit of normal around 40 or something. But 400 is definitely way abnormal, right? And it's dissociated from the cell. So this is an inflammatory pattern, but a non-specific one, Guillain-Barré, CIDP. And that white cells don't have to be 1 or 0. It can be, 10, just showing, wow, the protein is really high and the cells are not very high. Paraneoplastic, as you said. And then, yeah, good point. We're finding a demyelinating neuropathy. And right, when I heard the exam, I thought, yeah, I just know from experience and getting it wrong that you say it does look so length dependent. And yet that's why I've started saying it's not length dependent is distal and non-length dependent is proximal and distal. Those statements are true, but the nuance I've learned and so I've tried to add to my teaching is that demyelinating is still often distal predominant because the longest nerves have the most myelin, so they're going to suffer the most from a demyelinating process. And then there's motor involvement on the nerve conduction studies that's not present on exam. Yeah, this happens. Almost every EMG nerve conduction you get, it says the patient has carpal tunnel. They don't have any symptoms. They have ulnar neuropathy at the wrist. We're all doing lots of stuff with our wrists and elbows that are not very ergonomic these days, and you get some subclinical findings. So yeah, I guess the motor fibers are involved here, and the patient is not yet weak. The demyelination not sufficient to cause symptoms, or maybe the sensory ataxia is so profound, maybe it's hard to do the exam and really detect the weakness. So I trust Kirtan's exam. If he thought it was 5 out of 5, I believe him. And so this, again, the beauty of a objective test. Electrophysiologically, there's evidence that helps us further define this syndrome, now not as a subacute demyelinating sensory neuropathy, but a subacute demyelinating sensory motor neuropathy, because the physiology doesn't lie, right? Okay, so we have an inflammatory appearing subacute sensory motor polyneuropathy. What do you think the final diagnosis is, or are we not ready to say?
Sorry, you were asking.
Oh yeah, either of you or both of you, we ready
Okay.
with the final diagnosis here, or do you want any more?
Yes, I wasn't sure if you were asking a specific.
Yeah, sorry, I do that sometimes. I'm in the middle of saying something and I decide to turn it into a question rather than make a statement. My apologies.
Okay.
Yeah.
No worries. So if I have to guess, I would say that this could be a steel CIDP, if I'm not mistaken. This looks like CIDP, but I know very little about this genetic syndrome called Charcot-Marie-Tooth, so I can be mistaken. But since there is sensory and motor involvement, which is the sensory motor component of the Charcot-Marie-Tooth. I don't know it, and this would be a very good learning for me if Charcot-Marie-Tooth can present like that, but I would in my limitations of my knowledge, I would consider that in my differential diagnosis. And another diagnosis that I can still think about could also be paraneoplastic, just because of the sex of the patient, because he's a male, and males tend to have a lower incidence of immune diseases. and he's a young male, so it can be. Well, there are exceptions, right? Because Guillain-Barré, for example, is more common in males, but I think so, if I'm not mistaken.
You're right.
But it can also be an occult malignancy presented in this way as a paraneoplastic syndrome. So those are my thoughts, but my main suspicion would be CIDP.
Great. Rahul, final thoughts?
Yeah, yeah, I'm just agreeing with the Gerardo. I'm just thinking in terms of CADP. Yeah.
Yeah. So things going against CIDP here. Well, first, appreciate that you both had a differential and both expressed your uncertainty. So yeah, Gerardo used the language of, I don't know enough about this to say. I know it causes a neuropathy, and I'm not sure if this fits. So I just want to encourage here and in the quote real world, right? I'm saying, you know, I'm putting this on the differential, but I'm putting it on because of some things I know, not because I strongly suspect it or because I want to make sure we've thought about it or make sure I learned why it doesn't fit. Yeah, it's too fast, really. These CIDP, I'm sorry, Charcot-Marie tooth. I haven't seen that many cases. It's much more common on step 1 than in real life, but it is a very slowly progressive condition. And to end up in a wheelchair in 3 months, to my knowledge, just doesn't happen. Maybe Kirtan has a surprise for us here, but from my knowledge and the few cases I've seen, this is a very indolent, you know, like by the time the patient's presenting in, you know, 30s, 40s, they say, well, I was never very good at sports, you know, these kind of, I mean, I was never very good at sports either, but not because I had an indolent demyelinating neuropathy, or maybe I don't know yet. But it's not, it's the time course here that would argue against it. What we didn't hear about on the nerve conduction studies, I don't know if you have this, Kirtan, or you may have simplified for this purpose. With CIDP, you often, though not always, get a phenomenon called conduction block, which we don't have time to get into, which is a hallmark of acquired demyelination. It's specific for that, though not sensitive because it's not always there. But with genetic demyelinating diseases, you don't get conduction block. Essentially, all the myelin is being affected, so you don't get these little patches of block the way you do with acquired demyelination, which is a stochastic process sort of hitting a bunch of random spots on myelin and different nerves. I don't know if there was conduction block in this case, Kirtan, or there was not. Okay. And I looked recently because I thought a case could not be CIDP because there was no conduction block, and the neuromuscular fellow said, yeah, if there's certain parameters and the velocity is this low, et cetera, meets criteria. So I agree. This is what I would say is this fits for CIDP. It is a subacute sensory motor demyelinating polyneuropathy with a high protein. It meets the criteria, but part of any criteria for something without a specific biomarker is excluding other conditions. Are there any other conditions we've not excluded? We don't have an SPEP, or if Kirtan flew through it, I don't see it on the board, or I might have missed it. This patient would be young to have a paraprotein-associated disease, but that would be part of the workup of this neuropathy. We have an HIV test. HIV can cause both the Guillain-Barré-like syndrome and a CIDP-like syndrome and motor neuron disease and pretty much anything in the nervous system. Excellent article, probably from around 2013, peripheral nervous system manifestations of HIV in Lancet Neurology. Really good paper and humbling paper of all the different things HIV can do, but that was negative here. So I guess, would I be ready to call this CIDP? Would I need anything else? I guess the SPEP. And then I don't know yet, to be honest, do we start sending these paranodal antibodies on everyone? That protein is very high. If the tremor was really a major feature here, those, after my recent experience, so this may be recency bias, might be enough for me to say, if we can send those antibodies, we might do it because it does change the management. Or they're expensive to send. If you, like I do, work in the public system and they say, really, is it going to change the management? And you have to make the argument. You might say, this really looks like CIDP. Let's do IVIG. And if the patient gets better, we're on the right track. And patients with these paranodal antibodies do not get better with IVIG. I think I learned recently it's because it's an IgG4 subclass in these paranodal antibodies, and there isn't much of that in IVIG or something like that. I'm not immune. Don't quote me on that. Something like that, but IVIG doesn't work. Okay. So the only thing I don't think we've heard is the SPEP, though in this young age, I don't think it would be positive, and whether or not Kirtan's team thought there was enough here. and institutional support to send paranodal antibodies, or to call it CIDP, treat it, and see how the patient did. So again, so I just want to make that distinction. Meets criteria for CIDP, but not necessarily have other things been excluded to call it that. And there's a whole literature on misdiagnosis of CIDP. It's a very overdiagnosed condition. There's a big placebo effect from IVIG. And there's a series, I think, from Mayo of what % of patients went there with a diagnosis of CIDP who did not actually have the disease and were being treated with a medicine that is not without risk and requires a lot of resources for a disease they did not have. And sort of not surprising that this could happen when we don't have a clear biomarker, but important literature on misdiagnosis of CIDP. Okay, Kirtan, what did you think? What did you do next?
Perfect. And Aaron, meanwhile, I share the final record. Can you make me the co-host? Because in the end, I will share just 2 or 3 slides. That's it.
Yes, of course.
Perfect. Thank you. So as Aaron was saying that we need SPEP for sure. So we got the SPEP, we got the immunofixation free light chain, everything was unremarkable. And regarding the differential which Aaron was telling, so as we know, there are these rare syndromes like Canomad syndrome, Canvas syndrome, then Gallup syndrome. Like if you look at the acronyms of all of these syndromes, the 2 things you will find is they have neuropathy in them, they have ataxia in them. So definitely those things are a consideration. But the critical point is that all of them have paraproteins. And usually paraproteins you see in older people. Like it will be very hard to find a patient who has multiple myeloma at the age of 20 years. It's just not common. That's why. And similarly, in world of CIDP, we always want to send anti-MAG antibodies like myelin-associated glycoprotein antibodies. But again, they are seen mainly in people who have IgM paraproteins like Waldenstrom's or CLL. So you don't see them often. So by the way, in this patient, we did send the anti-MAG antibodies and they were unremarkable as well. So now regarding the final diagnosis and conclusion. So you guys got the answer. Let me tell you first that, okay. Now, how the story unfolded, because this case was special because of how the story unfolded. So this patient came first in 2009 at our hospital. And at that time, he was 23 years old. He had these symptoms for a while and he was diagnosed with CIDP eventually after like 2 months of workup while being in the hospital and in the clinic. They started him on steroids. Steroids didn't work. They gave IVIG. That also didn't work. Eventually, neurology concluded that maybe this is one of those 5% of CIDP people who do not respond to IVIG and steroids. So they gave 2 or 3 doses of rituximab. And then unfortunately, because of the social situations, patient was not able to follow back. And he was still in the wheelchair. There was not even slight improvement noted. Eventually in 2012, from what I can get from outside hospital records, he went to other hospitals surrounding my region. And all of the hospitals did similar workup as we did. And they also concluded that we don't know what's going on. Maybe it's CIDP, which is unresponsive. So they started Plex. Even Plex didn't work. Then in 2015, he found a private neurologist. He also concluded that maybe this is CIDP, maybe I will give a different regimen of IVIG. I don't know what that means, but they gave different regimen of IVIG. Still, it didn't pan out. And by this time, the things have changed. So now the patient does have some motor weakness. It is predominantly distal. In upper and lower extremities, it was like 3 out of 5, and proximally it was 4 out of 5. Eventually, he also developed contractures, and the contractures were so significant and he was in wheelchair all the time. So he ended up having multiple ulcers in the lower legs, osteomyelitis of the fingers, required amputation. Patient also had ulcers on the buttocks. Patient was actually admitted to the burn service for like 1 or 2 months. And it was just so painful and so sad. And eventually, because of the social situation, patient also had some drug abuse and patient left AMM numerous times. So all the services were kind of hesitant to do something which could be fruitful. So finally, fast forward to 2024. So in February, what happened was that this patient got admitted to the floors for the concern of osteomyelitis, not for the CIDP, because CIDP is in the background now. Patient has it for 15 years, he is in wheelchair, nobody even knows it. It's like diabetes now that we see in the past medical history, we don't think much about it, kind of like that. So my friend was telling me about, so this is actually my roommate. So like we always discuss cases at night, and my friend was telling that, hey, I admitted a patient, he was in wheelchair. I was like, that's unusual. Why would a guy who is in 30s right now, and at 23, he was in wheelchair? That's unfortunate. So I opened the chart. I went back all the way to 2009, looked at all the examination, And kudos to the neurologist who did such precise examination, like the cerebellar findings and everything. Without those examination, I couldn't have figured out anything. So I also asked the same question which Aaron was raising, that if you think about CIDP, the median age of CIDP is 50 years or 65. Not to say that CIDP cannot happen in young people. We have seen it even in 10 years of age, but usually we see CIDP in people who are above 50 years of age. So this guy is just 23 years. Regarding the dissociation which Aaron mentioned, we see CSF protein of like 150, 200, 250, but 400 is definitely like stretching the boundaries, as Aaron was saying. Other thing was the ataxia part. So if you look at the CIDP symptoms, there are so many variants of CIDP, but by and large, the motor involvement is classic. And isolated sensory involvement presenting as sensory ataxia is probably seen in 10% of patients. It's definitely not the major fraction. So that was also a red flag, that why would a CIDP present only with sensory ataxia and nothing else? The last piece of the puzzle was the response to steroids and IVIG. Now, about 80% of people will respond to steroids and IVIG at least a little bit. Now, this patient didn't respond even a little bit. Like, he was always in wheelchair, and in fact, he progressed while being on steroids and IVIG. So that was the final red flag. And that is what made me think that maybe I should send these antibodies. And I had read about this in like continuum neurology, that how these nodal and paranodal antibodies like contactin, and there is even Casper. Now, Casper is sometimes paraneoplastic as well. So I thought of sending those antibodies. So we sent those antibodies, and like about 15 days later, they did come back. So patient had neurofacin 155 antibody positive. And I also sent IgG4 levels, and IgG4 levels also came back high. Now, regarding the IgG4, what Aaron was saying, so if you think about the IgG4 related diseases, like systemic IgG4-RD and muscle-specific kinase positive myasthenia gravis. Now, in myasthenia gravis, we have acetylcholine receptor antibodies in like most of the people, but in 20% of people, we have these MuSK antibodies. And those subset of myasthenia gravis people don't respond to steroids. They respond to rituximab. So this is the weird thing about IgG4 antibodies, because they are predominantly produced by plasma cells, and the pathogenesis is very complex. But the baseline is that you need rituximab for these disorders. Now, this gentleman did receive rituximab 2 or 3 doses, but that's not enough. You need prolonged and extensive rituximab and nice follow-up. So that is what made me wonder that maybe we should send this. So eventually we sent that, and yep. And Aaron, can you make me co-host? I can share the final slides.
Yeah, you're co-host. Yeah.
I'm co-host?
So
Okay,
while
perfect.
you are getting them up, this is
Sure.
very
Aaron, can you see the slides?
Yes. Yeah.
Perfect.
Extraordinary diagnosis by Kirtan. You're going to teach us even more here, but
right.
Yeah, these diagnoses require dogged persistence, right? And really, it was red flags about the neuropathy that took someone to realize this is not B12 diabetes or something like that. But then you have to go one level further and understand CIDP well enough to know what's not behaving like CIDP here. And Kirtan pointed all of those out. A very high CSF protein, a very predominant sensory ataxic presentation, a tremor, and this distal predominance also is a feature of neurofasciin 155. Our patient had complete flail foot, meaning no movement at all of the foot, a lot of sensory problems in the hands, but proximally was quite strong. A lot of facial weakness. Our patient had also a very coarse tremor. Got plasma exchange, got rituximab, nothing happened. As Kirtan said, the nerves are demyelinated. The rituximab does not regrow the nerves. It just puts out the fire so that the house can be rebuilt and stop having these antibody attacks. And I just saw the patient probably, is it almost a year already? My goodness. I'm not sure how long it's been, but I guess 2 doses of rituximab, so a year. And this patient still has complete foot drop, but was bedbound. And so with foot drop, if you have orthotics and a walker, but can transfer to a wheelchair, can walk. And it's amazing to see if you can make this diagnosis, you can really help these patients. Otherwise, they're just called refractory CIDP. But CIDP, as Kirtan said, is not refractory. Part of the illness script is that it does respond to IVIG. So that is a red flag. So this patient is very lucky that they got osteomyelitis, not usually something that you're lucky for, but that ended up in Kirtan's hospital, that this diagnosis could be made. Kirtan, you're going to become a neurologist, right? Internal medicine is.
I can talk about that.
Yeah, okay. Glad to
So,
know you can talk about it. Okay, good. All
right.
right.
So Aaron, can you see my slides changing, or
Yeah.
are you seeing the same slide? Okay. All right, good. So this is, guys, the structure of neuron which I put here. So you can clearly see that how all the diseases which we commonly understand affect either the myelin or the axon, but we don't really talk about the paranodal region and the nodes of Ranvier. So this diagram clearly illustrates that how paranode and nodes are separate from the axon. And then this is a little bit complicated diagram, but basically you can see that MAG antigen at the top of your screen is present in the Schwann cells microvilli. Then on the downside, you can see the loops of myelin. And then beneath the myelin, you can see some antigens. And one of them is Casper. Then there is contactin. And then there is neurofacin 155. Then this is a little bit of a complex diagram from Nature's review. So you can again see that how there are so many antigens and antibodies which could be directed against this individual structures which are present on the axon. And then finally, this is more helpful diagram to visualize the landscape of CIDP. So you can see that there is typical CIDP, which is sensory motor, more than 50% of cases. Then we have asymmetric CIDP, which is like Lewis-Sumner syndrome, which is less than 15%. Then there is sensory predominant, which is kind of similar to our case, which is less than 35%. Then distal predominant, which is also similar to our case, 10 to 15%. Then there are monoclonal gammopathies. And finally, at the top of the screen, you can see the IgG4 mediated diseases. So there are like 4 antibodies: Casper, NF186, NF155, contactin, and all of these antibodies have their own stories. So for example, neurofacin 186, these people have nephrotic syndrome. So in this person, I looked back in the chart, made sure there was no nephrotic syndrome as well. That's why, as Aaron was saying, that when you gotta send the antibodies, you have to be precise because it's very expensive. So I decided that, let me pick 2 antibodies, contactin one and neurofacin. Maybe I will get lucky. And fortunately, I did get lucky that it was neurofacin. If it was Casper, maybe I would have lost it. So that's it. And this is the final diagram. You can see the center part of your screen that all the features which are mentioned, our patient was actually a textbook picture. Distal predominant weakness, sensory ataxia, poor responsiveness to IVIG, demyelinating features, and predominant IgG4 subclass. So that's why this story was so intriguing for me, because imagine that you have this diagnosis for 15 years. You have like steroids, plaques, and still the immune system is not dampening down. Because usually we see that in autoimmune diseases, you have lupus, you have systemic sclerosis and whatever, you have autoantibodies, but after a while, even if you don't treat, things go down on its own because that's how immune system behaves. But in this case, still immune system is on fire. The titers were so high, patient is still probably getting the damage to the nerves. And at this point, I cannot even imagine that even if patient gets rituximab, what's the benefit? Like, will the patient recover or not? It's hard to say. Maybe we can prevent the further progression in upper extremities, I guess, but not in the lower extremities. So finally, the reason why I said this was very close to my heart, because the day when I got this diagnosis, like you get that joy, you look at the sky and you heave the sigh of relief that, oh my God, this is like once in a lifetime. I don't think I will get this again. And that day, immediately who I called, the first person I called was Rabi. And then I called Maria, because both of them, I had to share this joy. And like, you don't cry from outside, but from inside, you have that joys of tear, right? I was like so emotional that 15 years and patient could have been lost. It's just that my friend mentioned me and I was there at the right time. And fortunately, it worked out. And eventually he left AMA, unfortunately, again. So if we hadn't obtained the test in the right time, we again would have missed this opportunity. And I don't know what would have happened to the patient. So now we are hoping that we will call back the patient. We'll try to find where he is situated. We'll give a trial of rituximab. Hopefully he improves. So you guys got it. So kudos to Dr. Berkowitz, Girardo, and Rahul. You mentioned midway around that how neurofacin can cause facial weakness, and neurofacin is actually situated in the Purkinje cells as well. Some research have suggested that's why these people can have cerebellar ataxia. So that was the final conclusion.
Well, there's only one thing to correct there, Kirtan, is that was your use of the word luck, because there was nothing lucky here. This was very few, probably even neurologists know about paranodal antibodies. These are sort of hot off the press and deep buried in the CIDP guidelines. So this is not luck. This is skill and talent. And I was going to try to recruit you to be a neurology resident, but I think we can all agree you're just ready to be a neurology attending, and you can skip the whole residency part. Really brilliant and extraordinary, and most importantly, very impactful to this patient. Yeah, another point here that we learned in our case is that these cases are demyelinating, but without conduction block for some reason. So that was an interesting feature. Do you know, with respect to the prognosis, Kirtan, was there axonal? Did you get a new EMG, or this is all old stuff?
So we had only one EMG, and that EMG had just demyelination, but I believe now it would have been axonal as well.
Yeah, so yeah, you asked about the prognosis, right? You do want to stop the process here. The patient presumably can use a wheelchair, meaning they have some proximal strength and probably some grip strength to be able to do that. So yeah, I think it is worth treating, but if you did an EMG and saw profound axonal loss, axons don't grow back, but myelin does at a very slow rate. I forget what it is. It's centimeters per month or something like this, but our patient slowly but surely was able to get out of bed. So I know we've gone way over. That's the nature of not just, it's the combined neuro VMR factor plus Kirtan factor, but Kirtan, you deserve the joy that you felt, and that's a joy, and making this diagnosis and helping this patient, and hopefully the joy you feel bringing this to us, so we can all learn and people can understand what CIDP is and isn't, when to think of it, when to think of other things. And I love the ones where the teaching points box gets so big that everything else is in 2-point font. So fantastic case, Kirtan, really off the charts, unbelievable level of knowledge and skill that you have. I think you're a neurologist. If you stay in internal medicine, okay, you can be every other specialty too, but hope we can think of recruiting you, or else you'll just be several fewer consults for the neurologist wherever you decide to set up shop as an internist. And Rahul and Gerardo, really brilliant discussion, very difficult case. You got to neuropathy right away, so it wasn't obeying the usual rules, and that it was probably demyelinating. And the rest that Kirtan was able to add on is a level I'm sure you will both achieve as you move forward, as Kirtan has, and seeing many more patients per unit time. Thank you all very much. This was a wonderful Saturday morning, and wonderful to see all of you and discuss this extraordinary case. And I hope you'll keep us posted, Kirtan, if you're able to find and treat this patient, and hopefully over time you can grow back some myelin and regain some function thanks to your incredible work. Thank you, everyone. Enjoy the rest of your weekend. You can hear this again.
Thank you so much.
On podcast sometime soon. Thanks, everyone.
Thank you so much. Goodbye.
Thank you. Bye.